Dear students, hope you have gone through my first video lecture on drug interaction. And in last lecture, the last topic that we have discussed was types or mechanism of drug interaction, right? And under that heading, we have checked two types or two mechanism of drug interaction, that is pharmacokinetics, right? We have learned that pharmacokinetic drug interactions are those type of drug interaction in which the precipitant drug alters the ADME of the object drug, right, with always a resultant change in a plasma concentration of the, you can say that, object agent, object drug, fine. As well as we have checked the definition of pharmacodynamic drug interaction, right. So it's a situation in those in which the drugs having similar or opposing pharmacological effects, they are administered concurrently, and you can say that situation in which sensitivity or responsiveness of the tissues to one of the drug is altered by another. Okay, so this we have learned definition. Why I am revising? Because today we are going to get in details of this pharmacokinetic drug interaction. Okay, so yes, so we are moving toward, yes, this was the assignment that I have given you in the last lecture. I hope that you have gone through this assignment, right. It is very important to go through this assignment. That will help you in better understanding of my video lectures, right, and will also give a idea, right, that what is the importance of drug interaction in the current pharmacy practice. That is what the aim of learning of this subject. Okay, fine. So moving towards the pharmacokinetic drug interaction, under this title we are going to check various mechanisms, right. So that mechanisms may be related with the alteration of GI absorption, maybe alteration of distribution, metabolism, and excretion. And that is what we defined in the pharmacokinetic, right. It is kinetics of ADME. Okay, absorption, distribution, metabolism, and excretion, right. So I've just gone through this list of this mechanism. Don't worry about that. We will get each and every details with a clinical important examples. Okay, as well as we are going to get some details of drug transportation also, right. So normally we check ADME, but with addition, right, we are also going to check the drug transportation interactions where the transportation is either enhanced or decreased. Okay, and we will also last, you can say, slide, we will get an overview of various pharmacodynamic drug interaction, right. So drugs having opposite pharmacological action, similar pharmacological action, alteration of electrolyte levels, and interaction at receptor. Each of these we are going to get in detail. So starting with the very basic of pharmacokinetic, you know that most common route of administration, right, that is oral route of administration. And once you take drug by oral route, right, the factors which influence the absorption of a drug includes concentration of a drug. Higher the concentration, higher is the chance that it will reach to the plasma. Definitely the lipid water solubility will also does have effect, right. More the lipid solubility, more will be the, you can say, chances of getting the drug absorbed. More is the non-ionized part, right. You know that ionized part is water soluble, non-ionized part is definitely non-ionized part is the lipid soluble part, right. So the pH of various, you can say that, compartments, right, that is stomach, small intestine, will also have influence on ionization of drug, and that will lead to definitely change in the absorption pattern from that organ. Acidity, definitely it is related with the ionization, right. Definitely pH of stomach is acidic, pH of intestine is relatively on the basic side, and GI motility also will have effect, right. Sometimes it is necessary, motility is necessary for the dissolution, and sometimes higher the motility, the transition time of the drug will be reduced, and such a case absorption could be reduced, right. So once a drug is given by oral route, there are some local enzymes present in stomach and intestine which could lead to metabolism, right. Also you know that pH will also destroy, say for example, acidic pH leads to hydrolysis of many drugs. After all, whatever proportion is been remaining, it could be absorbed through the stomach or maybe absorbed through the intestine, right. When we use the word absorption, definitely it means that the drug from the site of application, it is reaching to the blood circulation, right. Then and then it is said as a absorption process, right. Secondly, also once it is absorbed, it will go, right, because you know that there is a portal circulation, right, and that hepatoportal circulation, definitely there will be a significant first pass hepatic metabolism for some drugs. So liver is the major site of metabolism, and because from this intestine drug is been taken to the liver first and then into the systemic circulation, right? So first pass hepatic metabolism is also very important, and then finally the fraction reaching to the systemic circulation, that is what you call as a bioavailability. Okay, so these are various factors which could affect the absorption, or you can say that bioavailability of the drug, right? Why I have revised this, because these all factors you will need to consider when you check the drug interaction profile, right, of various drug, right? So that is why we have revised, we have gone through these factors that affects the absorption of a drug, right? So starting with the first one, that is alteration of GI tract absorption. Okay, gastrointestinal tract absorption. Okay, we are checking the possibility of drug interaction by various mechanism. Okay, so starting with the first mechanism, right, alteration of pH. Now you are well aware that drug, if it is, right, as we have discussed, that if a drug is non-ionized form, right, if it is in a non-ionized form, then and then it is definitely lipid soluble, and you know that this cell membrane, it is a phospholipid bilayer, so like dissolves like, and that's why non-ionized drug gets easy entry, right, through diffusion into, you can say that, this cell membrane and into the cell. And if this drug is in ionized form, definitely it is water soluble, and in such a case it is very difficult for this drug to enter through this phospholipid barrier unless and until there is a special transport mechanism available for such drugs. Okay, so this common, you can say that, knowledge, right, regarding your diffusion of your drug, right, entry of drug inside your cell is very important, right? And you know that, say for example, if a drug is a weakly basic drug, so in that case, weakly basic drug, it is very easy for diffusion across the large surface area that is provided by small intestine. If your drug is weakly acidic drug, definitely through small intestine, it is difficult to diffuse, right? So this is a normal property, and you also need to consider some specific formulations, like say for example, enteric coated medication. You know that enteric coated tablets, they are not, you can say that, allowing the release of that formulation in the stomach, right? They are designed to for such purpose, and once they get into the small intestine, right, the pH change will lead to release of that coat, and then finally drug releases in the small intestine, right? So such case we are going to discuss, right? So starting with the first one, that is ketoconazole and the antacids, right? So you know that ketoconazole is antifungal drug, right? It belongs to azole type of, you know that many medicated shampoos are also available having ketoconazole as a component, right? You learned in 6th semester BPharm. This ketoconazole can also be given by oral route, right? And normally it is absorbed through, you can say that, the you can say the stomach, right? Ketoconazole is absorbed through the stomach. Now consider a case that you're given with a drug antacids, right? Antacids, that here I'm talking is about your you can say that, H2 receptor antagonist, right? Or maybe you can consider proton pump inhibitors, right? We are not considering inorganic we are considering organic antacids. So ranitidine, omeprazole, both are definitely anti-secretory agents, right? These are proton pump. The omeprazole is a proton pump inhibitor. Ranitidine is an H2 receptor, right? Histamine receptor antagonist. And such a case, they will enhance the, they will comparatively, they will increase the pH in the because that gastric compartment, that is stomach. Okay. Once the pH inside the stomach is increased, now this drug ketoconazole, right, previously it was available in non-ionized form because the pH were acidic, right? pH was acidic in case of stomach. Now because you have given ketoconazole with antacid, now because the pH has been altered, ketoconazole will be in ionized form. If it is in ionized form, definitely the absorption, dissolution, and that is the reason why effectiveness of ketoconazole will get reduced. I hope you are getting this point, right? Now, because the pH was changed, right? That's why we are discussing under the heading of alteration of pH, right? And that is why the effectiveness of ketoconazole is decreased, right? So, if someone asks you, say for example, this pair will be given to you, ketoconazole and omeprazole, this pair is given to you. Someone will ask you, check the probability of drug interaction, whether this drug interaction is possible or not between these two drugs, omeprazole and ketoconazole. So what will be your answer? Yes, there is a probability, right? What is the probability? Probability is the effectiveness of ketoconazole can be decreased. Okay. So then what someone will ask you, what is the type of drug interaction that is occurring here? Then your answer will be, it is a pharmacokinetic type of drug interaction. Okay, in classification we have learned. Third question that someone will ask you is, that question arises is, by what mechanism this antacid decreases the effectiveness of ketoconazole? Then your answer will be, it is through alteration of pH. See, one by one we are checking all details, right? Type is pharmacokinetic, mechanism is alteration of pH. And then finally question arises, because such scenario if happens in clinical situation, and then question will be sent, right? Or maybe advice may be taken from clinical pharmacist, right? So what will be your advice? Because in a situation where drug patient is maybe is having some fungal infection, that is why ketoconazole must have been prescribed. And also the acidity, right? That could be the reason that omeprazole is being prescribed. It is also a case that sometimes antibiotics are given with antacids to prevent a reflex acidity because of the presence of drug. Such situation definitely antacids can be omitted. But if still situation ask for use of antacids, if patient is having a problem of peptic ulcer, GERD, and the use of antacid is compulsory, you cannot say simply that avoid use combined use of this drug, or maybe avoid any one of these drug, right? You cannot say that don't use antacids, right? Only take ketoconazole, or maybe you will say that stop using ketoconazole, start taking antacids. You cannot go for such advices, because use of both drug maybe you can say demanded by the clinical situation, right? Say for example peptic ulcer is there and fungal infection is also there, so you need to give these two drugs, both drugs has to be given, fine. But in that case what you can do is, right, what you can advise is, you give ketoconazole first, and after 2 hours of ketoconazole then administer antacids. Or maybe say for example antacids can be given after a gap of 4 hours, right? So specific gap can be given, right, between the administration of these drugs, right? And then situations can be, you can say that this is how you can resolve this situation. Also is a possible case that instead of ketoconazole, right, instead of ketoconazole you can advise some other antifungal drugs, right, where you can say that the pH dependent change in the absorption is not observed. That also is a possible thing, right? So such type of, you can say that advices, right, carry home message should be given by clinical pharmacists to patients, right? So this is how you solve the drug interaction, right? So we are checking the mechanism, also simultaneously we are also checking the outcome of this drug interaction, and we are suggesting a possible carry home message. Okay, that is what I will give you today. At the end of this lecture I will give you in a form of assignment. Okay, moving ahead with the second example is a bisacodyl and antacid, right? You know that bisacodyl is a irritant type of laxative agent, right? And because they are irritant in nature, right, they normally irritate the intestinal mucosa, and that is how they increase the peristalsis movement and they produces laxative purgative action. Okay, now, and that is the reason why bisacodyl tablets are always enteric coated. Why enteric coated? Because if this bisacodyl is released in gastric mucosa, in such a case gastric mucosa will get irritated, and once irritation of gastric mucosa is there, it will lead to strong nausea and vomiting. Okay, so that is a side effect that you can consider, and that is the reason why these tablets, bisacodyl tablets, are normally you can say that enteric coated tablets. Okay, now consider a situation, normally they are not released in the stomach, they are released in the intestine. If you give with antacids, now the stomach of pH is altered, right? You have given with omeprazole. Such a case, the pH of stomach is now altered, and now the tablet which were supposed to be released in intestine now will be disintegrated in stomach. Now, if the disintegration is in the stomach, then it will definitely lead to irritation and vomiting, and then patient will come to physician that what sort of tablet you have given, right? I have taken tablet for constipation, and because of this tablet I am having this vomiting, right, as a severe vomiting, right, as a side effect. And definitely patient will sometime will not come to physician also, right? He will start consulting another physician, right? So physician may not be aware of, right? Otherwise bisacodyl normally does not lead to severe vomiting, but if you give with antacid, then it may lead to such situation, right? So such combination definitely should be avoided. right? In this case, definitely you need to explain, you need to counsel the patient, you need to give advice to the patient that these two drugs should not be combined. Okay, so such is the important discussion that we have made under the heading of alteration of pH, right? So that by this we have completed the first mechanism under the heading of alteration of GI tract absorption. Moving toward the second one is a complexation and adsorption, right? And very well known example that you can narrate, right? You must have learned this in the chemotherapy 6th semester pharmacology. Tetracyclines are very important drug, right? And you know that these are broad spectrum antibiotic drugs. uh, Maybe it was considered as a very important replacement for penicillin antibiotics also at one time, and because of development of resistance, the you can say the role of this tetracycline in therapeutics was you can say that was lost at some point, but now they are reintroduced, right? Many you can say important infections now they are reintroduced, and this is a very much important category, right? But it's a very well known drug interaction. You must have learned somewhere in Shutics also, or maybe say for example in pharmacology also, that if you give tetracycline with milk or milk containing food, the absorption is is drastically decreased, and that is the reason is because they make a complex, that they lead to a chelate formation. You can just see that process of chelate formation with a divalent or a trivalent cation. So calcium, magnesium, aluminium containing antacids, or maybe say for example some foods which are rich in calcium like milk containing all type of products, dairy products, right? Then iron, right? Iron containing foods, right? Because Fe plus 2 is also divalent cation. Hematinics, right? Drugs which are used to increase the hemoglobin value, right? Which are used in treatment of anemia. All these they do contain metal, and tetracycline do have a complexation, right? With this all you can say divalent trivalent cations, and that reduces drastically, it reduces its absorption. Okay, so this is a classical example, and that is why tetracyclines are not to be taken with food or to be taken, right? That they are better to be taken on empty stomach, and especially they should not be given with milk. Why I am insisting this? Because normally what we say in say for example family, someone is ill, maybe say for example infection, because of infection fever is there, right? And in that case definitely what your mother will ask you, just take this medication with milk, right? ગુજરાતીમાં શું કહે આપણે, ભાઈ દવા ગરમ ના પડે એટલા માટે દૂધ સાથે લેવાની, પણ ટેટ્રાસાયક્લિન દૂધ સાથે લેવાય ના, ના લેવાય, right? So that is what the common scenario is, and that is what is been recommended. Fine, so this is a very famous interaction, definitely no description for this, it is well known to you. Similar case you can consider for fluoroquinolones, right? Fluoroquinolones, you know that norfloxacin, ciprofloxacin, right? These are very important drugs, and they are used in gram negative infection, okay, for treatment of gram negative bacterial infection. Also they are used for gram positive and anaerobic infection, but they are very important therapeutic agents, right? Such a case, same scenario, just like tetracyclines, the fluoroquinolones also do react with calcium, magnesium, aluminium, iron containing compounds, right? Or maybe food. In such a case fluoroquinolone also, the bioavailability, right, the absorption through the gastrointestinal tract is drastically reduced, and the mechanism is definitely complexation and adsorption. Okay, so here also definitely mechanism, if someone asks, you will definitely narrate the same, right? It may not be asked directly. Say for example you may be asked like ciprofloxacin plus FeSO4 syrup, likewise it could be asked. So FeSO4 ferrous sulfide, you know that it is a hematinic, right? Or maybe ferrous fumarate, so right, so that case definitely ciprofloxacin do react with such type of metals, and that metals do reduce the effectiveness of this antibiotic, right? You know that if subtherapeutic concentration of antibiotics like fluoroquinolone, tetracyclines are achieved in the blood circulation or at the site of infection, it could also enhance the chances of drug resistance. Okay, so such type of outcome also you need to consider. It is not just a simple decrease in the bioavailability, it is also related with the emergence of resistance of the medication, right? That also you need to consider. Moving towards the another important example is cholestyramine and colostipol, right? Now these are some of the drugs which you consider as a bile acid binding resins, right? These are resinous substance which bind with the bile acid, right? You know that bile acids are secreted through the, you can say that through the you can say that hepatopancreatic duct, right? That is from the liver, And these resins, right, once been administered, they are not absorbed through the GI tract, right, and they do bind with these bile acids. Once they bind with the bile acid, definitely they prevent the reabsorption, right. You know that bile acids are very important for the digestion of fat. Without bile, you cannot digest the fat, it is impossible, right. So definitely, because all enzymes, lipase enzymes, they do depend on the activity of these bile acids. Okay, so absorption of fat is dependent on this bile acids, and your drug cholestyramine, cholestyramine, they do prevent such type of digestion of fat by binding through the bile acids, and that's why they are anti-hyperlipidemic agent. Okay, so very important mechanism of action, right, for such type of a drug, right. Those type of patients who are not able to because that control their diet, right, in terms of fatty acids they are taking through the diet, such type of because that patients in combination therapy, these drugs are recommended, right. So but then this is the mechanism of anti-hyperlipidemic action of this drug. But along with the binding of bile acids, they do also bind with very important category of drugs. Drugs like thyroid hormones, drug like digoxin. See here, a low therapeutic index drug, right? Thiazides, warfarin. These are very important drugs. If cholestyramine binds with this drug, definitely their absorption also is decreased, right, and the therapeutic effect will be lost, right. So very important drug interaction that you need to consider. Such a case, definitely other anti-hyperlipidemic agents should be considered, right, and such type of drug you can say combination therapy, right, concurrent use of these, you can say, hormones, thyroid hormones, digoxin along with cholesterol should be advised not to be taken, right, concurrently, right. So this is regarding the second mechanism, that is complexation and adsorption. Moving toward the third mechanism is alteration of GI motility rate. You know that there is presence of various motility in the gastrointestinal tract, like say for example peristalsis, right. Similarly, segmental cysts, right. These are some of the motility which are present in the stomach and intestine, which is very much important for the, you can say that a passage of food, and similarly passage of drug also you can consider, right. So there are some drugs which can increase and decrease the GI motility rate. And one of that example that I've shown here is cathartics. Okay. Cathartics and laxative, you know that by various mechanism, they increases GI motility, right? And once definitely the GI motility is increased, the time required for dissolution of a drug is definitely given. And such a case, they do normally lead to reduction in the absorption, and overall transition period of a drug, that can definitely in your body in GI tract is reduced, and that is the reason why the, because that the effectiveness, the absorption of a drug is decreased, and definitely effectiveness of that drug also will be reduced. Okay, in some cases it has been noted that extended release or sustained release tablet, right, whole tablet have been found in fecal matter of the patient if a concurrent use of cathartic is been taken, right. Such is the effect that you can definitely consider, right, if such type of special formulations are being given along with the cathartics, right. Again, just if I in last lecture, if you just check and drug herb interaction, I've given you one example, right. Those patients who are using senna, right, senna is a ayurvedic like I said herb, right, which is used sometime in treatment of constipation, and in that case patient may not be aware of such situation, that's a use of senna, right, along with some antihypertensive, anti-diabetic drug can reduce its effectiveness, right. So definitely such scenarios can be considered, right. So all cathartics, right, if they have been given in the patient, definitely this type of drug interaction, possibility of this type of drug interaction should be checked. Okay, so say for example normally those type of drug which are absorbed slowly, or say for example which require prolonged type of contact, right, with the absorbing surface, right. And definitely you can consider this all formulation, enteric coated tablets, control release formulation, right. As I told you, some cases, right, worst scenarios, a whole tablet of control release formulation has been found in the fecal matter of the patient. Fine. Moving toward the next example is anticholinergic drugs. Anticholinergic drugs, you know that these are the drugs which we are discussing as an anti-muscarinic agent, right. Anticholinergic, when we say it, then you need to consider both anti because that is muscarinic receptor blockers as well as nicotinic receptor blocker, but here we are interested with the GI motility, so I am discussing anti-muscarinic agent. You know that anti-muscarinic agent, they reduces the GI motility, right? And this reduction in GI motility can be, you can say, correlated with either increase or decrease in absorption of certain drugs. Now this decrease in absorption can be understood from the previous point, right? Say for example, those type of a drug which require a slow type of an absorption profile, or which require a prolonged contact with the absorbing surface, definitely for such type of a drug, reduction in absorption and thus bioavailability can be reported. But how it will increase the absorption of a drug? So such case, definitely you need to consider that if there is a reduction in, you can say that, GI motility, it could lead to, you can say that, uh, this increase in absorption can be considered from, I'm very sorry, right, for the point that I've described. But then increase in absorption of certain drug can be considered, right, because we have learned that if drug is increasing GI motility, then the absorption is slowed down, right? Similarly, if your drug is reducing GI motility, definitely absorption can be increased because the contact time is prolonged. But how this anticholinergic drug can reduce the absorption of these drugs? So in such case, explanation can be, if there is a reduction in the GI motility, the, you can say, peristalsis movement can be reduced. If peristalsis movement is reduced, also the case that dissolution of this drug can be reduced, right? And such a case, reduction in absorption of a drug can be observed, right? So it depends on the property of the drug, profile of a drug, right? Drug characteristic will have a marked influence whether there will be increase or a decrease in the absorption, right? Most of the cases it will lead to increase in the absorption, but those type of a drug where peristalsis movement is necessary for the dissolution profile, such a case it could be a decreased absorption that could be noted. Okay, so this is regarding the, you can say, anticholinergic drug, right? One more example that you can consider is for prokinetic drug. Prokinetic drug, that is a metoclopramide, right? You know that metoclopramide increases GI motility, right? It is a D2 receptor antagonist as well as 5-HT4 receptor agonist, and by that virtue it increases GI motility. And definitely if it increases GI motility, definitely it can lead to reduction in the absorption of a drug which are given concurrently, right? Metoclopramide, you know that it is given for reduction of vomiting fear also, right? Some cases of GERD also it is being given, right? Many therapeutic uses definitely you can discuss, but if used concurrently with other drug, it can reduce the absorption of drugs by increasing the GI motility, right? That is the mechanism of drug interaction that you can postulate, that you can narrate for such type of a drug, right? So we have, up till now we have checked three different mechanisms under the heading of alteration of GI absorption. Starting with the first one, that is alteration of pH. We have checked that pH definitely could affect the absorption by changing the ionization fraction of a drug, right? And in that case, we have checked that if a drug like ketoconazole is given with antacids, the effectiveness can be reduced. Also, we have checked some of the enteric coated tablet like bisacodyl, which are not supposed to be released in stomach, but if by given with antacids, then definitely can be released in stomach and could lead to arisal of some adverse effect like nausea, vomiting. Similarly, second mechanism we have checked that some of the important antibiotics, right, like fluoroquinolones, like tetracycline, can have you can say complexation, right, can form a chelate with some of the metal ions, divalent and trivalent metal ions, and that could lead to reduction in its absorption and bioavailability. Okay. Similarly, we have also seen an example of cholestyramine and cholestyramine, which are bile acid binding resins, and they also do have a marked effect via complexation on the absorption pattern of some thyroid hormones, digoxin, right? These are very important categories. Third category we have checked is alteration of GI motility, right? Important thing that here is to note is the drug which can increase the GI motility, right? Example in that category will be laxatives, cathartics, some of the prokinetic agents like metoclopramide. Also, you need to check some of the examples of the drug which are, because of that, reducing the GI motility, and in that case you can definitely consider example of anticholinergic drug. Okay, so three, you can say, different mechanisms we have learned, right? Now we are moving toward the fourth category is effect of food. Now, effect of food definitely is an issue, right? Definitely you can discuss with many important drug, right? It almost on a minor level affects the absorption of all type of drugs. And if I'm not wrong, I discussed this previously also, right? That most of the drugs, they are designed, right, in the laboratory, right? Their formulations are designed in the laboratory to be released on empty stomach. Fine. So such a case, definitely food is going to have effect. That is definitely very sure, and that's why we mentioned in with the drug. Or say for example, when we go to physician, or maybe when we visit the medical store, what do we ask is, when should I take this medication, right? Whether it is in morning, afternoon, or evening, right? Or second question that we ask is, when should I take whether should I take this medication with food or without food, right? That's a common question that we ask, right? So first definitely effect is the with the effect of food, most of the cases absorption is decreased, right? Right, most of the cases, right? There are some cases, right, rare example, where with presence of food, the effectiveness or the absorption of the drug and thus viability of drug can be enhanced. That also is a possible thing. But most of the cases, presence of food will lead to either reduction in, you can say that, the absorption, or if not reduction, right, sometime what happens is, right, is a delayed effect of a drug. That is what, right? Now this also is a very important situation that we need to discuss, right? So two situation we are discussing. One is reduction in absorption, right? If there is a reduction in absorption, definitely bioavailability is reduced. But second situation what we are saying is, most of the time it is absorption is not decreased, but it is delayed, right? Say for example, drug was supposed to be absorbed completely by 3 hours, right? Once you give a tablet, after 3 hours of the tablet administration, it should be completely absorbed. With presence of food, the effect is produced somewhere around 6 hours. The absorption is completed after 6 hours. So here there is not loss, but just there is a delay in the absorption profile, right? Now this you can correlate with a very famous quote in terms of justification, right? We normally say that justice delayed is equal to justice denied, right? આપણને કોઈ કોર્ટનો ચુકાદો મળે, ભાઈ ચુકાદો 20 વર્ષ પછી મળે તો આપણે શું કહીએ, ભાઈ આની કરતાં તો ના મળ્યો એ જ બરાબર કહેવાય, રાઈટ? અન્યાય થયો એના બરાબર કહેવાય, એવું આપણે કહીએ હોય, રાઈટ? સો સેમ સિનારીઓ યુ કેન કન્સિડર in this case of effect of food, right? So that is what is been mentioned here. In some situation, effect of drug is delayed but not reduced, right? Where in most of the circumstances, the total amount of drug may be reduced, right? So this we will consider, we will understand with an example. Consider a case that you are taking a drug like alprazolam. Alprazolam, you know, that is a drug which is used as a sedative agent, right? And consider a situation, right, that normally tablet is been taken somewhere around 8 o'clock or 9 o'clock, right? So what normal scenario is, once you take a tablet at 8 o'clock, and in that case definitely sleep is going to be induced after 2 hours, right? 10 o'clock, 11 o'clock, a patient will now feel drowsiness and will definitely will have a sound sleep, right? That is what a normal expectation is. But if it is given with food, effect is delayed. Remember, it is not reduced, but effect is delay is not reduced, but it is delayed. So instead of 11 o'clock, now what you will have is, now the sleep is the drowsiness is been started produces somewhere around 1 a.m., right? And until that you will be awake, right? So definitely instead of the normal sleep which should be produced at somewhere around 11 o'clock in the night, right, you are having the problem in the sleep, and definitely here effect is delayed. But this delay in effect also is definitely a very much problem for the patient who are having the problems with the sleep, right? So such scenarios can be considered, right? When you take a heavy food, such you can say that effect, right, may be considered, right, that they are delayed. And delayed effect also is definitely is an important outcome, right, in a clinical scenario, right? So now let's check how the effect of food, right, alters the absorption of a drug, right? So possible reasons that have been discussed. So first, and a very visible reason, that is it slows the gastric emptying time, right? You once you take the food, definitely digestion process is going on, and that is the reason why it will lead to slowness of the gastric emptying. Second thing is, it is a physical type of a barrier that you are considering, right? So binding with drug is that is possible, right? And that's why the decreasing the access of drug to the site of absorption is a possible case, right? Say for example, if you take a heavy meal, such a case, if a drug is having some amines and your drug is also rich in proteins, so that will lead to amino acid, right? So say for example, classical example that you can consider here is L-dopa. Levodopa, right, is definitely an amine, right? And such a case definitely this is been otherwise not been absorbed freely through the diffusion, right? And such a case, levodopa has to be taken from the intestine, absorbed through the intestine by special transporter mechanism, L-amino acid transporter mechanism. That is how it enters into the your body, right? Absorption is dependent on the transporters. If you give levodopa with protein rich fluid, so definitely digestion of protein will lead to arisal of amino acid, and if amino acids are present, they will compete with these transporters, right, for the active absorption into the blood circulation, right? So and that is the reason why L-dopa is not recommended to be given with food which is rich in protein, right? Otherwise, a reduction in, you can say that absorption can be observed, right? Third important mechanism is dissolution rate could be altered. Most of the cases, as I told you, that dissolution is reduced, but some cases dissolution can be enhanced also, right? If I'm not wrong, gracioflovin is a drug where the dissolution is enhanced and the effectiveness is increased, okay? Also the case that you need to consider that some of the food are highly acidic, right? Say for example, food rich in vinegar, right? If you've taken lots of Punjabi food, right, તડકા લગાવીને ખાધું હશે, right, ફ્રેન્ડ્સની સાથે ગયા હશો હોટલમાં, right? So definitely in that case, acidic food also definitely will alter the pH, right? Stomach pH is altered, and that is why the ionization of the drug, that also is going to be altered. And if ionization is altered, definitely absorption pattern can also be altered, right? So these are some of the mechanism, possible reasons which could alter the absorption of a drug if taken with heavy meals, if taken with the food, okay? So definitely advice has to be given by physician only, right? It is not always that food will interfere with the absorption. Some cases the interference is negligible, 1%, 2%, 5%, right? In such case definitely the recommendation with food, without food does not make matter, right? Does not make any sense. But in situation where you statistically significant increase or decrease in absorption is there, then definitely advice to patient must be given that this drug is, it should be avoided with food or maybe without food, okay? So we are checking examples where the food interactions, which changes the absorption pattern of a drug, right? That is what we are going to discuss, right? So starting with the first example, antibiotics, okay? So antibiotics normally, right, if they are given with food, right, their effectiveness is reduced, okay? So and that is the reason why, say for example, here a classical example that I would like to give is rifampicin, right? Rifampicin, you know, that is a very important drug for treatment of tuberculosis as well as for some of the gram negative infections, like say for example meningitis, okay? And normally it is reserved for treatment of tuberculosis. You know that for treatment of tuberculosis only few drugs are available, right, which you consider as a first line agent. And in such a case definitely the bioavailability of rifampicin is very important, and it is related with the prevention of emergence of resistance, right? If subtherapeutic concentration of rifampicins are there, so it could lead to development of resistance also. And classically, right, rifampicin is always given on empty stomach. Why on empty stomach? Because this, if given with food, that presence of gastric juice, right, acidic pH will lead to hydrolysis and will greatly reduce the absorption and bioavailability of rifampicin, right? And that is the reason why in DOTS therapy, right, if combination pills have been there, and that pills are to be taken on empty stomach, right? So such a case definitely antibiotics, right, in such cases. Similar scenario you can consider for azithromycin also. Azithromycin is a very important drug, antibiotic, which is used for throat infection, right, upper respiratory tract infection, given on empty stomach, not with the food, okay? So this all situations definitely you have to consider. Some antibiotics you don't have such indications, say for example penicillin, cephalosporin, such indications are not there. They can be given with food, right? Their pattern is not I'm discussing about third generation, fourth generation penicillin, cephalosporin, right? There you don't have such type of an indications, okay? Moving toward the second example is acarbose and miglitol. You know that these are the drugs which are belonging to anti-diabetic category, right? So alpha glucosidase inhibitor, right? You know that what is alpha glucosidase enzyme? It is the enzyme which converts, right, the polysaccharides into disaccharide, monosaccharide, right. So complex sugar is converted into a simple sugar, and that's why this simple diffusible sugar normally gets absorbed through the intestine. Now, in those patients who are diabetics, who are not able to control their diet, these medications are given just before the food, right. Why they are given before the food? Because if they are given before the food, then they will inhibit this enzyme, right, alpha glucosidase enzymes. And if this enzyme is inhibited, then and that rise, rapid rise, right, in the glucose level of the patient can be prevented. Now consider a situation that patient has taken a food, and half an hour after taking this food, right, you are recommending, right, that or you are taking this medication. So after half an hour, all alpha glucosidase enzyme, right, that they have converted these polysaccharides into disaccharide, monosaccharide, and then if you give acarbose miglytol, it will be of no use, right. And that's why in anti-diabetic drug, doctor specifically mentioned that this has to be taken before food, this has to be taken after food, pre-prandially, post-prandially. That's a very much indication, important indication for anti-diabetic drug, right. So remember that acarbose and miglytol are to be taken pre-prandially, just before the meal, right, few minutes before the meal. That is what the indication for acarbose and miglytol. And as a pharmacist, you should be aware, right, if patient asks you that why before food, right, why not after food, right. Or if, say for example, patient is coming to you, you are prescribing the, you are dispensing the medication, then also, right, it is important to give such advice to the patient. Otherwise loss of therapeutic effect could be observed, right, or the proper management of sugar level, right, will be not achieved, right. Poor glycemic control will be observed in those patients, right. So this is a very important example. Third one is an extreme example, right, that you can consider, that is alendronate, right. Alendronate is a bisphosphonate agent which is used many a time in management of osteoporosis. And this is an extreme example that alendronate not only reacts with this simple type of food, it also reacts with simple fruit juices like orange juices or maybe coffee also, and extremely it also reacts with mineral water. Even if you give with mineral water, then also it, the effectiveness, the absorption is reduced, right. In such situation, doctor may give a prescription or may advise patient to take this medication with a demineralized water, right. Such is the situation that you can consider for some extreme examples like alendronate, right. So we have gone through various important example in this category, effect of food, right. So anti-diabetic drugs, antibiotics, right, some drugs like alendronate, right. These are very important examples which you have discussed under this heading. Moving toward the next is alteration of metabolism in the GI tract, right. Now normally you consider liver as a you can say that organ of metabolism, and that is very true also. Major metabolism of any drug definitely happens in case of liver, but a significant level of metabolism also do occur in GI tract, right. There are lots of enzymes, local enzyme present in stomach and intestine, which are responsible for the metabolism of a drug in the GI tract, right. So it is definitely dependent on the extent to which drugs are metabolized in GI tract, right. So we are considering those example only where the extent of the metabolism in GI tract for the drug is higher, right. So, and best example is this one, that is the drugs which inhibits MAO enzyme. You know that lots of MAO enzymes are present, right, in the your gastric gastrointestinal tract, right. Now why these enzymes are present here, right. The reason that the enzymes are present here, MAO enzymes are present here, is because sometime you eat the food, say for example pickled fish, right, or maybe say for example certain alcoholic beverages or aged cheese, right, not the normal cheese that you take from the dairy, right, special type of aged cheese, right, that all type of foods, they are having a high tyramine content, right. Now some of these are definitely non-toxic, but most of the time this tyramine containing food, say for example fish contain lots of tyramine, and this tyramine or maybe some other amines, they are very toxic for our body. In such a case, the detoxification process is done by MAO enzyme, right. That is the importance of this MAO enzyme in our body, right. So there will be local degradation of this amine by MAO enzyme, okay. But if, say for example, patient is having a problem of depression, and for that reason physician has prescribed MAO inhibitors, right? These are some of the examples of MAO inhibitors: phenelzine, isocarboxoid, right? Tranylcypromide. These are non-selective type of MAO inhibitors, most of this, right? And some of these are irreversible MAO inhibitors also. Now, if you block this enzyme, now definitely, and if you take along with this MAO inhibitor, you take a food which is rich in tyramine content, like say for example, aged cheese is been taken. Now there is no enzyme in the body which could lead to detoxification or which could lead to enzymatic degradation of this tyramine. Definitely now this tyramine will be available in systemic circulation, and once it is available in systemic circulation, it could displace your noradrenaline, right, from the noradrenergic neurons, right. Once there is a displacement, definitely there will be availability of high noradrenaline in the blood circulation, and that could lead to hypertensive crisis. Okay, this is called as a hypertensive crisis, and that's why in the label of the MAO inhibitors, right, these all drugs, phenelzine, isocarboxoid, tranylcypromine, it is mentioned that should not be taken with a food which is rich in tyramine content. Otherwise, a classical drug interaction, what we call as a cheese reaction, right? This type of a drug reaction is called as a cheese reaction could happen. I'm just showing an image. You can just see that tyramine in gut is normally metabolized by the MAO enzyme, right? So this 80%, right? You can just see that MAO A enzyme is the major one, and that is what is present is in the intestinal mucosa, right? And normally this whatever tyramine that is taken through the food, that does not reach to the blood circulation the high level. Why? Because there is local metabolism, right. And if you give MAO inhibitors, right, non-selective MAO inhibitors definitely will inhibit MAO A as well as MAO B. So such a case, now this enzyme is inhibited, now it will be in blood circulation. Once it is in blood circulation, you can just see that it will displace the noradrenaline, and this displacement will result in a significant increase in the sympathetic outcome. You can say that output is increased, and that could lead to what you call as a medical emergency situation, where it could lead to hypertensive crisis, right? A gradual and sudden increase, right? A sudden and consistent increase in the blood pressure level, that is called as a hypertensive crisis, that will happen. So this should be avoided, right? Cheese reaction is a very famous interaction, and this is exam point of view is a very important question, right? The interaction between MAO inhibitors, right? Some of this you will be given, right? Say for example, phenelzine along with the aged cheese, right? That is what you will be asked. So in that case, definitely you should consider the answer, right, as per described, as per we have discussed in the last few minutes, right? Second important example is with the grapefruit juice, right? Again, grapefruit, as I told you, is not grapes, right? Grapes are different, right? And grapefruit is a citrus fruit, right? Just like lemon, just like oranges, right? It is a citrus fruit, right? So grapefruit juice normally is taken by patient, right, in many countries. But then important to note that it inhibits the cytochrome P450 enzyme, okay, which are present in the gut wall, right? CYP450 enzymes are also present in the liver. Those are definitely important, but the CYP450 enzymes which are present in the GI tract also you need to consider, right? So here we are discussing the cytochrome P450 enzyme present in the gut wall, and that are important for the metabolism of some drugs which are especially having a low bioavailability, right? જો તમને યાદ હોય તો we have at the time of the drug related factors which could lead to increased chances of drug interaction, in that we have discussed that drugs having low therapeutic index, drugs having a narrow therapeutic index, drugs having low bioavailability profile, these are very, you said, frequently encountered in drug interaction, right? So say for example, calcium channel blockers, right? So similarly, statins, right, that is HMG CoA reductase inhibitor, right, you must be knowing, right? These are very important anti-hyperlipidemic drug like cyclosporine. These are having a low bioavailability profile, and if they are given with along with the grapefruit juice, this grapefruit juice inhibits CYP450 enzyme. Such a case, definitely metabolism is decreased. Now they were designed as per the low bioavailability, right? And now if the plasma concentration of this drug is increased, because here we have blocked the inhibition of the metabolism is there, so now the plasma level of this drug will be higher, and consequent adverse effect will be visible, right? It will easily cross the MTC level. MTC level, if they are crossed, the adverse effect regarding this, you can say, use of this drug could be observed, right? Grapefruit juice also, you can say that blocks some of the transporters, and in such a case, if transportation of some of the drug is blocked, it would result in a too little drug in the body, right? So two mechanism can be proposed. The one is definitely metabolism in GI tract can be blocked. Such a case, increase in the concentration of plasma concentration of drug could be there, increased absorption could be observed, and second is transporters also could be blocked, and in that case the absorption could be reduced, right? So this is regarding grapefruit, right? This is an example image showing the grapefruit, right? Grapefruit, use of grapefruit juice is common in some countries, right? And patient may not be aware of also such situation, so definitely your role, right, as a clinical pharmacist, right, definitely will come into the action, right? So with this, yeah, one more example in the same category, that is in the alteration of metabolism in GI tract, and that is phenytoin, right, with the folic acid, or oral contraceptive with the folic acid. So you must have heard about such type of a scenario, right? Say for example, folic acid sometimes leads to megaloblastic anemia. You know that megaloblastic anemia is because of the immature RBC, presence of immature RBC, that is megaloblast in the circulation. And you also know that to convert megaloblast into the erythrocyte, mature erythrocyte, you need presence of some maturation factor like folic acid, vitamin B12, right? So you can correlate the side effect of phenytoin like mouth ulcers or megaloblastic anemia with the folic acid deficiency, right? And that is what we are going to discuss, drug interaction, right, of folic acid and phenytoin. So let's check how phenytoin will lead to folic acid deficiency, how it reduces the absorption of folic acid, right? So you know that folic acid we are taking directly from the diet, right? In case of bacteria uses PABA like sources, right, to synthesize folic acid, but in case of human it is available from the diet, but it is available in a poorly absorbable form, that is polyglutamate form. And in intestine there is a presence of an enzyme which is called as the intestinal conjugase enzyme. So this intestinal conjugase enzyme converts polyglutamate, here there is a spelling mistake, right? So it is polyglutamate, right? So folic acid polyglutamate gets converted to monoglutamate, right, by the use of enzyme intestinal conjugase enzyme. And drug like phenytoin, oral contraceptive, they do inhibit this intestinal conjugase enzyme, and by that virtue they reduces the absorption of the folic acid, રાઈટ. અને ગુજરાતીમાં શું કહીએ આપણે કે ભાઈ અમુક દવા લઈએ તો ગરમ પડે, મોઢામાં ચાંદી પડે, રાઈટ. Mouth ulcer is a common problem with many medication. How that mouth ulcer is produced? One of the reason why mouth ulcer produces because of the deficiency of folic acid, right? So here you can correlate adverse effect of these drugs like oral contraceptive, phenytoins, right, with such type of a drug understanding of such type of a drug interaction. Okay, so very good clinical important example we have learned. Moving toward the last you can say mechanism under the heading of the alteration of GI tract absorption is alteration of GI flora. Okay, so changes in the microbial flora of the GI tract caused by antibiotic definitely could either alter the production or metabolism of some drug, right? So this is very important, right? And this we are going to check with again clinically important example, right? And you know that which drugs do modify the GI flora? Of course it has to be antibiotics, right? And especially broad spectrum antibiotic. If you remember in chemotherapy we also discussed the arisal of super infection like adverse effect, which is also a big problem with the broad spectrum antibiotics, right? But here we are discussing, we are going to focus on the drug interaction, right? So first example is digoxin and antibiotics. Now digoxin, 10% of the metabolism, right, that is by reduction mechanism. You know that by for metabolism major you can say mechanism that there could be some many chemical mechanism responsible for that, but reduction mechanism, right, of you can say that metabolism for digoxin is attributable by the presence of this bacterial flora, right? So this bacterial flora are responsible for up to 10% of metabolism of digoxin, right? Now 10% you will say that sir it is negligible type of an, but consider that digoxin is a drug where the therapeutic index is narrow. Okay, and if say for example if you give a drug like digoxin with some drugs like azithromycin, right, erythromycin, tetracycline, then this bacterial flora is going to be modified, there will be it is going to be disturbed, Once the bacterial flora is no more available, the metabolism of digoxin will now not happen, right? Because it was the bacteria that were responsible for the metabolism. You given antibiotics, that's why this bacterial flora will be lost. If bacterial flora is lost, no metabolism will be there, right? Or metabolism will be reduced. If it is reduced, plasma concentration of drug will be enhanced, and that could result in a toxicity of digoxin, right? Because therapeutic index of digoxin is narrow. So very important example which we have discussed here. Second example here is oral contraceptive, which also I discussed many a time, right? Now remember that oral contraceptive can be given in a form of mini pill like progesterone only, or maybe sometime it is given in a combined pill like, say for example, estrogen as well as progesterone. Such a case, the metabolism of estrogen is very important to understand here, right? You know that there is a presence of enterohepatic circulation, right, for metabolism of many important drugs. So once, say for example, been taken by oral route, in such a case, definitely the drug will be absorbed from the GI tract, will be taken to the liver. In liver, you know that phase 1 and phase 2 metabolism reaction will occur. Phase 2 reaction, they are referred as a conjugation, right? You know that many important conjugation like glucuronide, sulfatation, right? These all could happen in case of liver. So estrogen is primarily conjugated by liver, and you know that conjugated form of estrogen is water soluble. But remember that estrogen undergoes enterohepatic circulation. That means once conjugated estrogen is been produced by liver, it will be released through the bile in intestine. Intestinal bacteria again removes this conjugation. That means it again converts estrogen in its original form, and that is responsible for long half life, right? Prolongation of half life of estrogen, that increases the biological half life of estrogen, right? And remember that this is because of the bacteria, right, which are responsible for, because of that this mechanism, right, they are responsible for conversion of this conjugated, you can say that estrogen, right, again in its normal estrogen form. Now if you give this estrogen along with, you can say some antibiotic like ampicillin, right, so in that case definitely they reduces bacterial flora, they will interrupt the enterohepatic circulation, and resultant reduction in serum estrogen concentration can be observed. If it is observed, definitely you can consider that the purpose for which the contraceptives were taken, right, combined estrogen pills, they are taken for purpose of contraception. That clinical scenario, right, clinical output could be different here. Although it is been considered that it is not that significant, but if, say for example, if any chance that definitely if it has been there, that it leads to conception, it leads to increase in chances of pregnancy, definitely other methods of contraceptive should be advised by a pharmacist or physician in such case, or the because that antibiotics which are not disturbing the bacterial flora, narrow spectrum antibiotics should be recommended, right? So definitely here very simple mechanism, right? Again I am showing an image here, right, where the enterohepatic circulation of the estrogen has been shown, right? You can just see that this is a very important, so you can just see that. So here it is been taken by oral route, right, and then this liver is producing the conjugated estrogen, right, which via bile, right, this enterohepatic circulation is coming into intestine, intestinal bacteria is again converting in estrogen form, and such a case definitely, if say for example this bacterial flora is lost, definitely the reabsorption, intestinal reabsorption of this deconjugated estrogen could be modified, which could result in its you can say it, contraceptive action. Okay, so this is the reason why some cases if antibiotics are to be recommended, other method of contraception should be adopted, and oral contraceptive should not be relied upon. Okay, so with this we have completed almost every category, right, mechanism of drug interaction with a clinical important example, and just go through the detailed revision of these topics. Okay, so and with this we are also completing this today's lecture, right, and I'm giving you an assignment, definitely as always, right, you need to work harder, right, as I am working harder for preparation of your video lectures, you also need to work hard. So first thing is you need to check the possibility of the pair which I've given just, right, so these are the pair for which you need to check the drug drug interaction, whether drug drug interaction is possible or not, that is what you have to check. First one is for penicillamine, milk of magnesia, rifampicin with food, lovastatin with grapefruit juice, and tetracycline with heparin, especially in patients who are having low dietary intake of vitamin K. Now, for if this all pair of the drugs, right, you need to check possibility. That is first assignment. That is first work that you need. If you find that there is a chance of drug interaction, then you need to check all this. What type of drug interaction is there? Whether it is pharmacokinetic or pharmacodynamic. If it is pharmacokinetic, what type of mechanism? Whether it is affecting absorption. In case of absorption also, if it is affecting by alterating pH or maybe alterating GI flora, or what type of mechanism is there, that you need to check. Then what is the possible outcome? Is it harmful or is it a adverse type of a drug interaction? And then finally you need to give a carry home message that whether this drug interaction can be avoided, whether if to reduce the chances of drug interaction, can other remedies can be given or not, or maybe a gap between two drugs can be given or not. That type of advice to the patient to prevent such interaction you need to give. So 4 pair I am giving, very simple task, but definitely you need to refer the books. I have used 2 reference book. One is Parthasarthi and second is Remington. Okay, and second assignment is is a brainstorming session that you need to go through, and that's a case study, right? You can pause the video, you can just go through these sentences which I have written. So very important type of address. This definitely will help you to go for a higher order thinking, right? And learning also will be enhanced, right? If you go through this case study problem based learning approaches, right? So that definitely will enhance your skills. Okay, say for example someone is willing to go abroad, maybe for US or UK or Australia, right, for higher studies, right? So in that case definitely this case study based learning will help you a lot. That is my guarantee. Okay, and if say for example if someone is definitely wants to stay in India only, then also such type of problem analysis will help you in understanding of the topic in a better way. Okay, chalo. So with this I'm completing this lecture. Last lecture, right, third lecture will complete this whole topic, right, and with this we'll complete the drug interaction. Okay, so thank you very much.